getting good physicians that can, represent the patient as well as the hospital. I think that's whenever you have a good hospitalist is someone that can walk that fine line. That's not something we've actually talked about to this point, but that's a key part of my job is not only representing my patient, but also keeping in mind, what's the responsibilities of the hospital.
Hi, welcome to the Dr. Gil Show. This is where we talk about medical matters that matter to you. My guest today is my friend and colleague, Dr. Trey James. Welcome to the show, Trey.
Thanks, Gil.
Trey has been my friend for many years. Trey is a hospitalist at Boone Hospital here in Columbia, Missouri. I'd really like to talk to our audience about what is a hospitalist today. Somebody goes to the hospital and they're admitted, and this doctor they've never seen before is there taking care of them. Mm-hmm. I want them to understand what a hospitalist is, and hopefully that'll be very valuable.
I think it will be.
Excellent, excellent. Now, Trey, you are a medical doctor, and you've done the usual training a doctor has. You go undergraduate, and I think you even have a bachelor's degree and a master's degree.
I do.
What was the subjects were those in, or what were your majors, as they say?
So I majored in biology for both undergrad and for a master's degree. Most doctors don't go to get a master's degree. Whenever I was completing my bachelor's degree at Mizzou, I felt like my application to medical school was going to be lacking because I really didn't do any research in undergrad. At the same time, I was starting to get very involved in wheelchair athletics. We can talk more about that here in a second, but decided to go to the University of Illinois to do a master's program in biology and participate in wheelchair athletics at that time.
Interesting. Was that a year or 2 years?
2 years.
2 years. I did that too. I did a year of graduate school after undergrad. I felt my application wasn't as complete. Yeah. I didn't want to apply, and then you don't get. Then you get, and the next time you apply, you say, "Have you ever been rejected from medical school?" Right?
Exactly. Who wants to go through that?
Right. And then you did your residency in internal medicine.
Correct.
Was it at University of Missouri here in Columbia?
No,
was that wrong?
I did.
Wake Forest.
Yes. So I matched at Wake Forest University in Winston-Salem, North Carolina, and in about a 10-day span, I got married. I graduated medical school, and I moved to North Carolina. All in about 10 days. Yeah, it was pretty crazy. But completed my residency in internal medicine there, and actually stayed on and did academic medicine or practiced in a academic hospital for 3 years before we moved back to Missouri.
So internal medicine residencies, usually 3 years, I believe.
Correct.
Sometimes they'll be an extra year. They'll do what's called a chief residency year in a lot of programs.
Yep.
And after internal medicine, a lot of people will get fellowship training, gastroenterology.
Correct.
And it's my understanding that a number of hospitalists will sometimes get what is it? I wrote this down. It's geriatric medicine or palliative care.
So you can do those things. I can tell you that even though I'm not board certified in geriatrics or palliative care, I do a lot of that.
Yeah.
I do a whole lot of that.
Internal medicine is geriatrics a lot.
So I think that there's also programs that you can do in hospital medicine, like a fellowship in hospital medicine. I see most people that want to do research in hospital medicine doing those types of fellowships. The practical side of it, though, is it's really hard to monetize those types of additional training. So try to monetize a fellowship in hospital medicine, monetize geriatrics, or even palliative care. So what I mean by that is, you go a long time to go to medical school, go through residency, you're kind of getting paid not nearly what you're worth. So if you go on to do a fellowship, you're just adding on to those years where you're really not producing an income that justifies spending the decade of your 20s in school.
Right.
So you really have to kind of, if I'm talking to a resident or even a medical student, I bring that up because, you don't really think about that when you're going through the process. Like I took 3 years, a total of 5 years to get my bachelor's degree. Gee, I wish I had that year back now.
Right.
If I hadn't done a master's degree, would that have moved me further along in my career? Yeah, it could have. But it might not have. It's those questions in life that you really don't know the answer. I'm happy with the decisions I made, but you just need to be careful about some of those decisions, whether they're going to be profitable for you in the long run.
Yeah, the return on investment. Exactly. So internal medicine is the study of kind of general medicine. It's kind of an interesting turn, internal medicine. Of course, it's internal medicine.
Back in the day, they used to say you're the pediatrician for adults, and that's probably the easiest thing to understand. But internal medicine is you're taking care of someone from the age of 18 till death. So our family practice friends, they get the claim of from birth to death. For me, I don't ever want to take care of a child. So even 18 to 25, I get kind of nervous about. It just the stakes are pretty high there.
Sure. So you graduated from with an internal medicine training residency, and you said you went right into being a hospitalist or hospital care. What was it about doing internal medicine in a hospital setting that was attractive to you?
Well, I really like sick people.
The challenge.
Yeah, and I mean, as part of internal medicine training, you still have to do some clinics and take care of healthy people and try to maintain health. And it was okay, but to do that 8 hours a day, 5 days a week, just seemed miserable to me.
To you.
And I was much more happy when I'd be in the hospital, I'd have my cell phone in one hand, a house phone in another, talking with a nurse, trying to put in orders, just more or less my hair's on fire and the world's just speeding by. I find that enjoyable. I like that. I like that, to be able to interact with somebody at their worst and bring them through that and bring them back to health. That's kind of my calling, I feel like.
And you're good at that. And people usually gravitate to what they're good at, what gives them fulfillment, excitement. I've talked about my choices a number of times here.
Yep. And, you were alluding to fellowship. So after somebody completes an internal medicine residency, they have the ability to go on to do cardiology, nephrology, gastroenterology, any of the ologies, really.
Right.
And I did a lot of work in all of those through residency, and did a lot of inpatient medicine on services, cardiology, nephrology. And I enjoyed that time, but I never found anything that I'm like, this is awesome. I just want to take care of people with kidney disease the rest of my life.
Yeah.
Just I like the variety. I like the fact that there's often a diagnostic dilemma that you have to take into consideration when you're looking at a patient. You're always going to get this story most often, for my patient populations are originating in an emergency department, either in your hospital or somewhere else. You're having another physician tell you what they think it is. And then you have to ask yourself, is that really what this is? Or,
right.
And I enjoy that.
Yeah, it's like a mystery, and you got to be a detective, and it is intellectually very stimulating.
Yes.
In your position. I've heard a hospitalist being described as a quarterback. You got to run the whole team, and you've got specialists here and the nurses and at all these departments that you have to bring to bear.
I would concur with that. I often use that analogy myself, just to make patients understand the process. So, as you pointed out earlier in the conversation, I don't know any of these people that become my patients before I go into the room and introduce myself for the first time. And probably the hardest thing in hospital medicine is developing a rapport and establishing credibility with your patient.
Yeah.
So you're not going to convince somebody that's sick that you know what you're doing if you're not credible, if you're not trustworthy, and to try to develop that, those are qualities that often take weeks to years even.
Yeah, it takes time.
And I've got to be able to do that in about 5 to 10
10
minutes.
minutes.
Yes.
Wow. So hospitalist as a specialty, did that come about in the 90s or earlier? Do you have any knowledge when the concept of a hospitalist started?
So the first time the term hospitalist was coined was in the New England Journal of Medicine. I believe it was in the maybe 92, 93.
Okay.
It's by an internist in San Francisco at the University of California, San Francisco. His name's Bob Wachter, and he's considered the father of hospital medicine. I've heard the guy talk several times. Amazing guy. And he was the one that first said, healthcare is getting too complicated. If you look back into the 70s and 80s, we had primary care providers that would see patients in clinic all day, see people that are sick, say, hey, you need to go to the hospital, send them to the hospital. I don't know when emergency medicine really started to take off, but everything the history that I've heard is, you'd have these doctors sending their patients to the emergency department, but there was nobody there to take care of them. So we had to have emergency medicine. So then emergency medicine would admit these patients and kind of put them in the bed and hold for the primary care doctor to get done with clinic and then come over and see them.
Right, they'd come in out. I remember as a kid, I got kicked in and my kidney was bruised. I remember being in the hospital and we had to wait until the doctor finished clinic in the office and would come in the evening almost as an afterthought. So you'd sit there and languish. Which nowadays, in cost controls and you can't do that. You better be getting something done.
So with that and lifestyle, I mean, could you imagine getting up about 6 a.m. or 5 a.m., going in, rounding on your patients, rushing to clinic, spend 8 hours to 9 hours in clinic trying to get all your patients seen, all the documentation done, and then, hey, I had to send 3 people over to get admitted. I'm going to have to go see them
back to the
now.
hospital. It's just overwhelming.
So with that forethought, I think what Dr. Wachter at that time was foreseeing was you're going to see lots of primary care doctors say, I'm done with inpatient medicine. It's too complicated. There's all these new regulations. There's all these expectations. And I've got all these patients to care for in the clinic as well.
Right.
So you saw a large number of primary care providers leave hospital settings, and you still need doctors. You still need people in the house that can provide that care. So hospital medicine has kind of progressively become more and more popular throughout the nation. And I would say, Boone Hospitalist program started, I believe, in about 2008. And I came in 2012, and it's just kind of grown each year. Sometimes it's retracted, but for the most part, we've progressively gotten larger and larger. And now probably in the next year, we'll be taking care of all the patients that are admitted to the hospital that are not OB-GYN.
Right. Right. And things can happen. Now, I could see if you're in a teaching hospital where you have residents all the time running around. If somebody has a code or has an acute medical problem, all the residents can rush in. There's doctors there. But if it's a community hospital and there's no hospitals, what happens if somebody decompensates is our term for it at 2 p.m. and then there's nobody there?
They call me.
They need hospitalists. So the need for a hospitalist has become very apparent. And apparently when it started out, the hospitals realized they needed it, and I guess there's regulation issues. Apparently there was a huge demand and low supply. So it was easy getting a job.
Yes, very much so.
I understand it's gotten a little tougher now. It's maybe more of a coveted position, maybe fewer spots, more applicants.
I mean, I think that more so so primarily hospitalists are going to be internal medicine trained. My internal medicine residency, I probably spent 30 of 36 months of my residency in the hospital.
So you're already there. You're already
Yep.
familiar with that setting.
Yep. So whenever you look at, other specialties that do hospital medicine, family practice does some, but they spend the majority of their residency in the clinic.
Right.
So, it's a really easy transition for internal medicine into a hospitalist role. Now, that being said, you have a lot of internal medicine residents that want to do a specialty. So back in the day, I would say that probably 50% would do a specialty and 50% would do clinic. And now I would say that 50% that was doing clinic is probably doing hospital medicine now. So, and there's just always going to be kind of this demand of getting good physicians that can, represent the patient as well as the hospital. I think that's whenever you have a good hospitalist is someone that can walk that fine line. That's not something we've actually talked about to this point, but that's a key part of my job is not only representing my patient, but also keeping in mind, what's the responsibilities of the hospital and what job does it have to complete to say that this was a successful hospitalization. A lot of times that's different between the patient and the hospital, and you as the physician have to be the kind of the person that says, no, we do need to do this, or no, this has to wait.
Yeah, a lot of difficult decisions. So you alluded to this, and it's something that I saw when doing my little bit of research before this, is that a hospitalist sees people that are too sick to be treated and released from the emergency room. So somebody comes in with a bad medical problem. Obviously, if it's stitches, they stitch them up, send them home.
Yes.
If it's an appendix, they call surgery, they get their appendix out, and bam, they go home the next day, for example. There's a lot of people, older people, complex problems, something that's not so simple. Maybe they get stabilized in the emergency room and they have to be admitted to the hospital. So is that the typical way that a patient would come under your care?
Very much so. I would say probably 80%, probably even more like 90% of our patients are going to originate in the emergency department and come into the hospital through the emergency department. Now, I would say of that 90%, probably 70% of them originate in our emergency department at Boone Hospital, and probably 30% originate at a referring emergency department.
So they'd be brought to the hospital via an ambulance, for example?
Correct. So they would call, say, hey, we've got this patient. We think they're having a heart attack. Will you accept this patient? We'd say, absolutely. They arrange an ambulance transport, and they come directly to a bed on the floor.
So they don't go through the emergency department. They go straight to a bed.
Correct.
And see a hospitalist like you that has tremendous experience in something like a heart attack.
Absolutely.
Something like renal failure or something like that.
Yep.
Yeah, that's really important, Trey. In many things in medicine, the volume, the experience, the amount of cases a person sees breeds familiarity and expertise.
It does. It can also get you too comfortable and get the blinders on. So you always, from my point of view, I always try to go down the road of, I think this is what this is. Let me start ordering the confirmatory tests. Oh, don't fall in love with a diagnosis. I've said that numerous times to people that I'm working with. Don't fall in love with a diagnosis, because as soon as you fall in love with it, you're going to put the blinders on and forget about something else.
You'll develop a bias.
Yes.
And you won't see things. I love getting pearls out of these, Trey, and there's a pearl right off the bat. Don't fall in love with a diagnosis. I'm going to use that personally. Thank you.
Go right ahead.
Thank you very much. So here you have a sick person, frequently comes as a referral from another hospital or through the emergency department. And there you are. They've never seen you before at all. You've never seen this person at all. So you don't know, is this a person that doesn't like to be in the hospital is going to say, "Oh, I'm fine, doctor," but they're really sick.
Yes.
You don't know their personality, or somebody who's always the complain. I don't want to use the word complain, but the Debbie Downer.
Right.
I woe is me, and they're really not that sick.
They come in all flavors.
All flavors.
So farmers. Farmer shows up in the hospital. It's something big.
It's big. They are tough mofos.
They do not come to the hospital. So when they start telling me how much better they are and how much the better they feel, I have to walk them back and no, there's some stuff going on here. We've got to figure this out.
Yeah, because I'll tell you a true story. Well, one that was relayed to me. The doctor I bought my practice from, he came from Nebraska. Famously lived in a dirt floor root cellar when he was in medical school. Tough old guy. And he used to do ambulance work and when he was a medical student and a resident. And he had this farmer had his thumb chopped off and some farm implement. Farming is dangerous as well as anybody. And the doctor's name was Larry. And Larry told him, well, we're going to have to transport you to Omaha and we'll get you we'll get it reattached, and the farmer goes, no, just bandage it up. It's harvest time.
Exactly.
I mean, and you got to understand, how's that for a city dweller? That doesn't make sense. But think this person has toiled and sweated and gotten loans, and the wheat is there in the field.
It's time to work.
You got to get it in.
Yep.
So his thumb was, it's tough farmer. I work without a thumb. Just bandage it up. I need to get back to harvest.
Exactly.
And when you look at it from that point of view, it's understandable. So you got a tough old farmer. I'm feeling better. He wants to get out of here, but he's got this piece of dead heart here from what's called a myocardial infarction, perhaps, or a pneumonia. Or give me some idea what kind of. Maybe I shouldn't ask you what are all you'll have to go through every chapter of Harrison's. Harrison's is the classic internal medicine book. But just so people get a flavor, you've got heart attacks.
You've got cardiovascular stuff. You've got infectious disease is a big component of my practice.
Fevers, sepsis, bad infections called sepsis.
Correct. From all variety of sources. Term we use, metabolic encephalopathy, which is kind of the vogue term for altered mental status. Somebody's just not active. Somebody's just not active. Right.
And as a medical student, they always say, what's the difference between dementia and delirium? That was always
I'm an expert in that.
Right. Go into room 20. Does this person have dementia or delirium?
Yep. So I mean, it just the whole gamut. And I mean, mental illness it's a huge time suck. I mean, you can spend a lot of time with a patient trying to figure out what the problem is. Secondly, if they're unstable, psychiatrically unstable, they can become dangerous. And that's not something that I necessarily signed up for. Thirdly, there's all types of antipsychotic medications that I don't use, and the ones I do use are at different doses than what a psychiatrist uses. So even though I can kind of play along and help out and try to get things where they need to be, it's just not something I really want to do or feel comfortable doing. And so, but that being said, it just kind of goes to show that in hospital medicine, you really need to be somebody that can pick up and do anything at any one time, even if it's not really in your wheelhouse.
Gotcha. So you're well-versed. And you mentioned having the phones in your hand.
Yeah.
You've got to know who you can call, who you can trust. And you might know that now psychiatrists are there's so few of them.
I don't have that. I do not have that at Boone Hospital, and that doesn't make Boone Hospital a bad place.
It's a nationwide shortage.
Absolutely. And, how we were talking about in terms of primary care doctors not coming to the hospital, psychiatrists definitely don't want to come to the hospital.
And they've got a lot of telemedicine. I mean, the one psychiatrist he covers 5 or 6 emergency departments.
You could do your care from home and not have to leave the house. Yeah. That could be appealing. So,
Yeah, and we had Bob Frazier on here that's it's a plug for another podcast. It's called Evolution of Psychiatry. And even the meds that I learned are now old. And
Exactly.
they've got all these new ones and new doses and interactions. And
Yes.
so we need help, sometimes from various specialists. And for example, there's we have a bunch of excellent surgeons here in Boone, and you would know that Ben, for example, is good at this, and Ann is good at this, and
Absolutely.
Reggie's good at this, and you would know who to call.
Absolutely.
You know, so being the quarterback, whether it's a handoff or a pass or calling the play.
You know what's super interesting is how medicine has changed with text messaging. You know that makes my world, my life, so much easier to be able to, hey, are you here? I need your help now.
Yeah, are you down the hall or you're at home?
Exactly.
Or in Jamaica?
Yep. And being able to converse about a patient and know what their game plan is versus what my game plan is. I just don't know how we would have done that even when I started residency and we didn't have text messaging.
Yeah, phones used to have cords on them, folks.
Exactly.
Yeah, yeah.
Exactly.
And if the other person wasn't hearing the ring on their phone, it didn't happen.
And you remember the flip phones? I mean, it's not like there was a keyboard.
Right, yeah.
So, I mean, the iPhone should probably be up there along with MRI machines as being some of the biggest contributions to medicine.
Yeah.
It might sound weird, but good Lord, I don't know how I'd do my job without my phone.
The truth is the truth. And let people know about, we usually will say, hey, are you available to chat? We try to avoid sensitive patient information on things that aren't HIPAA approved.
Correct.
But if you can get the guy's attention or the gal's attention.
And honestly, I feel like a mob boss sometimes.
Yeah.
Hey, you know that guy?
That guy.
That guy that's down the hallway that's got the thing on his...
That guy.
That's how you get around that.
Right.
You never have to put anybody's name or phone number or date of birth in there.
Right.
You just describe them.
That's great. Now... I ran into some myths. We all, it said that, internal medicine doctors know everything but do nothing. And surgeons know nothing but do everything. And pathologists know everything, but it's always too late to help the patient. That's we all have these stereotypes about us. OBGYNs, we have our own things that people make fun about us about. So one description of a hospital is, you're just a triage nurse that just admits the person, gets them in, and then just, calls the various people to take care of them. That really couldn't be farther from the truth, could it be?
I hope not. I hope that's not the truth. I don't practice that way.
I know you don't.
Do I see hospitalists that practice that way? Yes, I do. And at Boone Hospital, we've done very hard work to try to maintain the fact that we are doctors and not secretaries.
Right.
I think if you go to bigger hospitals that have fewer hospitalists, you can overrun a hospitalist with enough patients that they really don't have time to be a doctor, because if you're trying to see 30 hospitalized patients in a day, you're not going to be able to talk with them very much. You're not going to be able to interact with them very much. You're not going to be able to think about what's going on. So we've been very lucky to be able to maintain appropriate census per physician that allows us to still be doctors. Yeah. But I really, when you hamstring a physician, or if the physician willingly goes into a role of not really providing care and just calling other people to do it,
right?
I have to ask, why'd you go to school for so long?
Right.
That's not why I went to school for so long. It's not why I stayed away from my, was kept away from my family on Thanksgivings and Christmases for years on end. I did it so I could provide care and help people get better.
And really help people.
Yes.
Yeah. By the way, emergency room doctors, they get teased. They're just they're just family doctors with a CAT scan.
Right. Valid.
We can spread this around.
Yeah. And I don't think there's any inpatient physician, whether it be surgeon, hospitalist, cardiology, anybody that practices inpatient medicine doesn't, you know, throw down on the ER physician. But I will say for my ER colleagues, that's got to be one of the toughest jobs in the world.
Oh yeah, we had Orlando here. We had
Yeah.
another podcast with him, and I tell you what a job.
You know, the things that they need to know. I mean, it's really, I try to tell my younger colleagues that, you know, I don't know how to stop a nosebleed. I kind of know, but I don't know how to put a rhino rocket in. I don't know how to reduce a boxer fracture. There's all these things that they have to know that, plus a large portion of what I know.
Right.
So whenever they call me and ask, hey, what do you do in this situation? Instead, I have some colleagues that perceive that as, well, you should know this. No, they really shouldn't.
No.
They know enough, and they know enough that they can call me and I can help them out, because that's what we do as colleagues.
Yeah, it shouldn't be about ego. And I always tell my nurses, don't be afraid to ask me a question. If you're not absolutely 100% sure, ask me.
Yep.
Ask me, because it's not about us. It's about patient care. It's about patient safety.
Absolutely.
Taking good care of these people. And one other thing about hospitals, people might think, well, maybe there's not. The reason they're hospitalists is they don't have enough business sense to go out on their own and to have a clinic or something like that. When in fact it might be much more satisfying to do high level care and be able to clock out.
Right. You know, it's one of those things that healthcare has changed a lot, and you know, I think that probably through the 70s, 80s, and even into the 90s, we build being a doctor as, oh, get your shingle out, throw it up, and just start seeing patients, and you got your clinic, you got your little secretary, you got your nurse,
Right.
And see your patients, and that's how you make a living. I don't want to really be a businessman. And to run a practice, you need some sort of business sense.
Right.
I hate the idea of ever having to say you're fired.
Oh yeah, it's a whole different. And I didn't have any business training. I've had to kind of learn on the fly.
Yep.
It's not pleasant sometimes.
Yep. So by me being a hospitalist, I don't have to worry about any of that. I don't have to maintain a clinic. I don't have any overhead.
Right.
You know, I don't have to worry about who's going to be on call for me 24/7. You know, it's just, to me, that's a better lifestyle. And I think that as we transition through the generations, we're seeing this more and more.
Oh yeah, fewer and fewer medical students. I think it's down in the single digits. Want to have a private practice.
Yep.
Yeah.
Yep. So really what's probably what we're going to see moving forward in the 2030s, 2040s is you'll have large medical group practices. So, hey, we have 100 cardiologists in this group and it's still a private group. Or you're going to see, oh, we're all employed by the hospital and everybody uses the same EMR, which is really more or less the model of academic medicine. And, you know, there's a lot of problems with academic medicine, but one of the things they got right, in my opinion, is everybody's on the same EMR. You can communicate much more easily. You know, whenever your patient ends up in the ER, you get a little email. You can see what happened. You know, there's that benefit. Everybody is employed by the same person or same entity, so you all have a stake in the game.
Yeah, an EMR is an electronic medical record. They have their problems. I hate them, but it's like nowadays you can't live without them.
No, not at all.
You can't live without it because you have to be able to communicate, and it's like another language. If you're comfortable in that language and you've learned that language, I know my students, when they come through, they're all just, they don't know any other way, and it's very smooth for them.
Yep.
And so, Trey, you got a real sick patient, and they need to go to the intensive care unit. How does a hospitalist mesh with the intensive care unit in your line of work or in your model?
So It varies, and it kind of depends on how sick they are and what's going on. If I'm dealing with a cardiac arrest, so code blue goes out over the hospital, and all hands on deck. Anybody that can come comes. And if you're the first doctor on the scene, it's your code. You take care of it. Might not be my patient, but it's my patient not right now.
Okay.
So in those circumstances, I'm often, if it's a cardiac arrest, we're telling people to do CPR, what medicines to administer.
You're directing the code. It's
Exactly.
called. You've always people snap to attention. They know what to do in an experienced hospital.
Yep. And I'm the guy if I'm the one in charge telling everybody what to do. And then if we're successful in getting the patient back, next thing I'm doing is texting or calling the ICU physician saying, hey, we're coming down. This is what's going on. Be ready for us. Hey, we might need to intubate as soon as we get there. Or, hey, I need you to come up to this room and intubate now because I don't think we're going to be stable enough to transport without a protected airway. So there's that type of interactions. I've got a patient that I feel needs to be on a medicine that I can only deliver in the ICU. In those circumstances, I'm probably just going to hold on to that patient. And if they deteriorate further, maybe I get an intensivist on board. Intensivist is kind of a hospitalist that only hangs out in the intensive care. Right. So I like to have options, and to have a intensivist available is always reassuring to me. But again, as I said, I like taking care of sick patients. So once I've developed a rapport and the patient trusts me, or I feel they trust me, they're my family, and I'm going to take care of them, and I'm going to do everything I can to continue to be their doctor.
So they're not going to lose you. So if a patient is hospitalized under your care and we call go south or go sour, or get really sick and go to the ICU, you're still going to be there being the quarterback and being intimately involved in their care.
Yes.
That's fantastic.
And that's probably more unique to me than industry standard, but that's just how I practice.
And people know when you're in a community, people know that Trey's good at this and he's going to do this, and Mary's going to do it a little differently, and Karen's going to do it a little differently. And
they probably also say about Trey is, yeah, you don't want to do that because he'll really be mad at you if you do that. So.
That's fantastic. So you've got somebody in the hospital, they're getting better. You've treated their problem, they're starting to heal. We got to get them home, maybe to a nursing home. Mm-hmm. You got to get them better so that they can go home. So you have all these things all these resources that you need to muster. We have social workers. So give me some idea, Trey, of when you use various rehab services. There's occupational, there's physical, speech. Right. There are all these things. When would you bring in those resources to get somebody home?
Quite honestly, as soon as somebody is admitted to the hospital, we need to be thinking about what's the discharge plan.
Really? Right off the bat, you're already thinking the whole arc of their care.
Correct.
Huh.
So if you look at a standard length of stay for any diagnosis, we should be shooting for 4 days or less.
Really, you can take care of most problems in the hospital in 4 days or less.
Correct.
Wow.
Sounds kind of crazy, but honestly, for a hospital to be profitable, you need a length of stay of 4 days. If you start getting into a length of stay of 5-6 days, on average, you're not going to be able to keep the doors open.
You got to keep the doors open.
Got to keep the doors open.
So we got to supply quality care, help these people.
Yep.
And do it in budget.
Yep. So in terms of this idea of when do I get my additional staff involved, PT and OT consults are ordered on admission.
That's physical therapy and occupational therapy.
Yep. Speech therapy gets involved if we're concerned about patients not being able to swallow. So if they cough
Yeah.
with
It's almost a misnomer. It seems like a lot of speech therapy is can a person swallow and breathe? And it's kind of important.
yes, I mean, there's more often than not, one of the reasons people go to hospice is they've lost the ability to swallow and they don't want a feeding tube. So it's a huge thing. This is probably for another time, but there's certain things that you can't live without, and one is you can't live without your small intestine. Did you know that?
Yeah.
Can't live without it.
Right.
Kind of like a heart or a brain. You can't live without those, but you can't live without a small intestine. You can't live unless you can take in nutrition, one form or fashion. So
yes, and the small intestine, folks, is where you absorb your nutrients.
exactly.
Yeah.
So in terms of speech therapy, that's whenever we get them involved. Is if we're concerned about a swallow problem. My social work, they're going to be the ones that are going to send my referrals to different facilities. Sadly, in healthcare today, we really need to kind of know what their patient's insurance is. So
Right.
if they have standard Medicare, they have the best insurance you can possibly have. If you have let me clarify that. If you have standard Medicare plus a supplement, you have the best insurance for rehab after hospitalization. If you have Medicare without a supplement, it's pretty good. You're going to have a significant out-of-pocket expense if you need a prolonged rehab, like with a stroke or something. But if it's something short, that's pretty good. Probably the worst thing to have is the Medicare replacement plans. And those are being marketed very heavily to the senior population because it was perceived as being less expensive for CMS, who manages Medicare, and trying to reduce the cost of care for patients. I think they found that it doesn't do that, but I think that genie's out of the bottle at this point.
I see. Boy, that's a whole nother topic.
It is.
Yeah, for another time. So if somebody has an unstable home environment, or I guess the nightmare scenario is you have a person who is homeless. Social work is crucial in trying to find some kind of step down or someplace they can go to get out of the expensive hospital.
Valid. And it kind of depends on the functional status of the patient. If the patient is able to walk and get around, then sometimes we just have to discharge them to the street. I mean, we can't fix that problem.
You can't build them a home.
Yes. If they have some sort of disability, if they have Medicaid, then sometimes we can get them a Medicaid bed at a nursing home.
Okay.
But there comes problems with that. There's often psychiatric illness that is prevalent in a homeless patient's population.
Dual diagnoses.
Yeah. So in those circumstances, a lot of nursing homes don't want to get involved in stuff like that. So it's a huge problem, and again, that's why you have to identify these problems right off the bat and start coming up with a game plan for discharge, or you're going to have a patient sitting there for months. And that's not uncommon.
And hospital rooms are unbelievably expensive.
Most expensive hotel in Columbia, Missouri is Boone Hospital.
Boone Hospital. I'm a surgeon, and people say, "Well, how much is this going to cost?" And they assume the surgeon's fee is going to be, it's trivial. It's almost nothing. The cost of being in an operating room under anesthesia, pre-op, post-op, that's just unbelievably expensive.
Sadly, it's mind-blowing to me myself. I mean, I'm in healthcare, and I'll have patients tell me what their bill is, like friends, and I'm like, they charged you that much?
Right.
I mean, it's just kind of flooring at times.
Yeah, and a lot of hospitals, small community hospitals, are just going out of business.
Yes.
Out in the rural areas, they just can't make it float.
Exactly.
And once again, another subject. So we have to have economies and compassion and all these resources to try to take care of these people. Are there any other departments or services that are valuable to you in treating patients and getting them home successfully. Is there anything I haven't talked about yet? Obviously, if somebody has a surgical problem, you can refer to the surgeons, and we've talked about psychiatry. And somebody has a heart attack, you might bring in cardiology. And
you just kind of have to take a look at the patient. I grew up in a program that, when I refer to that, I mean the residency program that I trained at. It was a little malignant. I don't know if you ever been in a malignant program, but
I was.
Yeah,
as a medical student.
Yep. So whenever you call a consult, you better speak with confidence, or they're going to eat you up. And it got to the point where I just didn't want to call a consult, so I just learned how to.
I'll do it myself.
Exactly. So, and that taught me a lot, and even to this day, I probably consult fewer than anybody else in my practice or my group. So it's just one of those things that, there's certain things I have to get a consultant on board for. End-stage renal disease, I have to have a nephrologist because they're the only ones that can do dialysis orders.
So there's a turf right there. You got to be nephrologist with privileges to do dialysis. And we have dialysis in the hospital?
Yes.
Because there's a lot of freestanding centers that.
So those do outpatient, and there's actually a difference between outpatient dialysis and inpatient.
To explain, please.
I don't know the specifics. I just know that in a hospital that has inpatient license to do dialysis can't bill for outpatient dialysis because we run into those types of issues with somebody that might have been a bad boy or girl at outpatient dialysis and got fired, and now they don't have any dialysis centers to get dialysis. What do? They often show up to the emergency department once a week and go get dialyzed, and the hospital doesn't get compensated for that. That's just lost money. But when you live in a community and your hospital is a community hospital, that's some of the things you have to do to be a good player in the community.
Yeah, I tell my patients frequently, this is a two-way street. We have to work together.
Yep.
Right. We may not like each other. We may not have the same politics, but we have to work together.
Yes.
As a team, and it's a process, and you have to respect each other. And for one reason or another, sometimes somebody doesn't work well in the system. I'll just sugarcoat it that way.
Right.
You don't do much teaching. It's not a teaching hospital. But do people come through? Do you teach students of any sort?
I do, to a certain extent. I really like teaching. Honestly, if this whole medicine thing hadn't panned out, I probably would have been a biology teacher, high school biology teacher. But most of my patients will say, "Gee, Dr. James, you explain it in a way I understand."
Yeah.
And to me, that's me educating. So
right.
I get the education fixed by explaining to the patients what's going on with them, why they're sick, how we're going to fix that, and get them home.
Yeah, and another thing that's maybe you don't appreciate until you're in the hospital with a child or a loved one or a parent is talking to the family and explaining things.
Yes.
And if the physician's not there or something happens, somebody comes in, they got some time off from work, they come in for an hour and the doctor's not there, they want an explanation, of course,
yes.
Right? And I know you're very good at explaining things, by the way. Your reputation precedes you.
Fair enough.
Yeah, and that's really, really nice.
I tell people I speak Missouri. That's
Missouri, yeah.
That's my specialty. I speak Missouri.
Yeah, it's called the show me stage, famous for being blunt.
Yeah.
And wanting, no, I don't want platitudes. I want some evidence, please.
Yep.
Yeah, and there's nothing wrong with that. So Trey, what in your life persuaded you or made you think, hey, I want to be a doctor when I grow up? Was it something that happened early? I've told this story a number of times. When I was 5, I operated on my Bugs Bunny that the ripcord didn't work, the speaks it. So I did a vertical midline laparotomy, opened it up, somehow fixed it, sewed it up real nice. Did a beautiful repair.
Did he survive?
Survived for many more years. And I knew at age 5 that I wanted to be a surgeon. There was something gratifying, fulfilling about that. Did you have a moment in your life and you said, hey, I'd like to be a doctor?
I can tell you it was not in my grade school years. I was a terrible student.
Well, that okay, but you don't have to be. That usually doesn't figure into the decision, at least.
So
you might want to be a fireman, and you're not very,
fair.
All right.
So I probably started. My mom was a nurse, so I was exposed to healthcare through her. My father was a farmer. I was injured in a farming accident when I was 14 and was left as a paraplegic, and spent about 3 months away from home my freshman year of high school, initially in the hospital, in the acute hospital, actually Boone Hospital, and then went on to do rehab at Rusk at the university.
Big rehab center here.
Yep.
Famous.
So spent a lot of time around physicians and nursing and everything at that point. Spent some more time the next summer doing some rehab down in Columbia. Again, spending a lot of time with medical students and things like that. And I'm like, this is kind of cool. I kind of like this.
So it's your teens.
Yeah. So really liked science. It's kind of the one thing that I can like anything, but usually if we get to a certain level, like I really like trigonometry, but calculus, I can learn it, but I don't like it.
Yeah.
It's a little too abstract.
I drew the line at differential equations. They almost killed me, Trey.
Yeah. So the biology specifically was the one thing that I could get hip deep in, and I still wanted to know more. So thinking medicine would be a good profession, enjoying biology, figured, hey, that this could work. When I was I guess it would have been a sophomore in college, started working at Boone Hospital in the medical intensive care unit, spent 3 years working weekends there, and got to see internal medicine physicians work on a day-to-day basis.
Role models, mentors.
Yeah. And
people you admire.
Some I was like, I'm never going to be that kind of doctor.
Yep. Sure.
And with that, I'm like, I had the grades, and it just made sense to at least try to take the leap. Med school is kind of like the lottery. I mean, it's not quite as random, but at times you think it's random.
Being admitted, you mean? Or
yeah, getting into medical school. I knew a lot of people that I thought were really smart that didn't make it.
Yeah. Yeah, and I look back. I probably would have gotten in if I had applied the year earlier. I was afraid.
Yeah.
Yep. And sometimes we're our own worst critics.
I think that refines us into smoother diamonds.
Yeah, smoother diamonds. Well, I'm learning a lot about the work you do as a hospitalist. I'm seeing how important it is to have the continuity. And in fact, when I was training in OBGYN residency, an edict came down from on high that you had to have a continuity clinic. Mm-hmm. So you'd see a person not just randomly here and there, but you'd see a person through the whole cycle of, GYN clinic and their health, and then maybe they get pregnant and seeing them through the pregnancy, and then the postpartum and the fall, seeing the whole thing. And that not only teaches you more, but develops these relationships with your patients that I find so rewarding.
I would 100% agree with you, and that's one of the downsides of hospital medicine, because more often than not, I'm going to be that patient's physician for maybe a maximum of 7 days.
Right.
That's how long I work on a rotation, 7 12-hour shifts. Then I get 7 days off. One of the things I do on my days off is I'm the medical director for a facility here in town called Columbia Post Acute, which is considered a nursing home, but really all we do is the rehab aspect of it. So we were kind of talking about where do our difficult, complicated patients go after discharge. One of the places they might go is Columbia Post-Acute, and it's what we'd consider post-acute rehab. So after you've been hospitalized, go someplace like Columbia Post-Acute, work with a therapy team. And I've been doing that for about 10 years in total. I've been at Columbia Post-Acute for probably 6. And that continuity I get with that to a certain degree. It's not a continuity from when I establish care with them, maybe in their 30s till they die, but it's more of a continuity of from when they got sick to when they've gotten better. And that's something that, again, you miss out on hospital medicine, and I think it gives you a better understanding of what to expect with a 90-year-old hip fracture. I can tell you a 90-year-old hip fracture, that's going to be about 6 weeks of recovery. And I can tell that to the patient right then whenever they fractured their hip. And again, goes to, hey, this guy actually knows what he's talking about. He sounds pretty legit and knows what I'm going to have to go through to be able to become independent again. It also gives you the ability to say, hey, mom with dementia now has this debilitating illness. I know this isn't going to go well, and I'm going to give you the foresight to know what it's going to look like and your options, and being able to be straight with people and very honest with them. Not a lot of times it's stuff they don't necessarily want to hear, but need to know.
They need to know. And in retrospect, almost everyone is grateful for that honesty and that foresight that you mentioned.
And if they're not, I just say, you want me to lie to you? I can lie to you too.
Well, there's a quirk too. There's people have these little verbal tics and stuff that they have. And one of them that I really hate, well, to be honest, it's like I'm talking to a patient. Well, to be honest, it's like I've really been hoping you've been honest the whole time. And I know it's just a phrase and it's a saying, and people aren't admitting to dishonesty, but it's one of the ones I don't like, to be honest. Well, to be honest, Trey, I've learned so much about a hospitalist from you today. I've got a much better idea about what you do, and I think our listeners and our viewers are going to have a much better idea too. So if they're admitted to the hospital and they see a completely new face, but it says doctor or hospitalist, I think in general, I can cast a wide net here and say that hospitals are very well trained. They're probably going to give you better care than in the hospital setting than a primary care or a family doctor in the clinic doing what they're doing. But in this setting, hospitalists are here and they're here to stay, it seems.
Would 100% agree.
100%. So I think it's a field that was only going to grow and maybe evolve like everything. We have a friend named Delwood. I keep wanting to get him on here to talk about artificial intelligence, and how are they going to help us wade through all these diagnostic difficulties and quagmires and biases we may have and whatnot. So still going to continue to evolve, but it seems like it's a very necessary specialty. So I appreciate your time being here. And Trey, on a personal note, I want to tell you that I really admire you, and seeing how you handle the phones and the responsibilities with your physical disabilities is truly inspiring to me, and I really admire you.
Thank you.
It means a lot to me, and I think you probably inspire more people than you may realize. I don't know. But I know your reputation is fantastic, and I know you help a lot of people, and you're a real asset, not only to Boone Hospital, but this community.
Thank you.
So I want to thank you for being here today. Maybe you can come back some other time, and we can talk about this a little more.
Sounds good.
What a pleasure having you, Trey. Thank you so much.
You bet.